So the thing I'm going to focus on pretty much today is treatment for LAM, and particularly rapamycin or sirolimus, which is the other name for it, which is the name most commonly used in the States. Rapamycin's been a treatment for LAM for a good few years now. And as we're using it more and more, we're learning more and more about it. We've known for some time that it's effective in a certain population of women with LAM, but what we didn't know is perhaps the long-term effects, the long-term durability, how frequent the side effects were, and how people dealt with that. And the ability that we have when we see people at the LAM Centre is to record a lot of this information and to try and use the people's experience of being on the drug to inform clinical care and be able to talk to patients, give them better information about whether they should take the drug or not. So what I'm going to talk to you this morning, if I get through all of these things, is really how rapamycin works, how it affects LAM particularly, a little bit of the evidence from the original studies about the benefit of rapamycin, and some more up-to-date data that we've collected and just published in the respiratory journal Thorax, looking at the slightly longer-term outcomes of treatment with rapamycin on the lung disease. And then just talk a little bit about who the drug works best for, what the effects are, and then just finish really by putting it in context a little bit. I had hoped to get your views for the people who are on rapamycin about side effects and about your feelings on it. I have to say, I think usually the most successful parts of these meetings are when people with LAM talk about their experiences and share those. So I'm hoping if we've got a bit of time that we can have a bit of a discussion about rapamycin. So if you have particular views on the drug or points that, as I'm going along with, I'm going to focus on talking about them at the end. So the first thing we need to do is tell you a little bit about cell biology. So those of you who don't like biochemistry, look away now. So rapamycin works on something called the mTOR pathway, and you need to know a little bit about this to understand this. Rapamycin and its sort of sister drug, everolimus, are called mTOR inhibitors. The mTOR pathway is a series of proteins, shown here, all with really quite tricky names. And the job of the mTOR pathway in nearly all cells is to govern how the cell grows, how it metabolizes its nutrients externally. It can also affect cell survival, and it can also affect whether the cell's able to move around the body, to migrate, to metastasize. So it's a very important pathway, and the mTOR pathway really assimilates signals that tell the cell what to do with the information about, well, actually, have I got enough nutrients, enough building blocks to do that? And if the answer to that is yes, it allows the cell to change its behavior in some way. Now, this is a really powerful system, and it's mostly switched off. If it's switched on all the time, the cells grow too fast, they move around, they change the metabolism. And there's a specific braking system that affects the mTOR pathway. It's a group of proteins, and two of them are tuberin and harmatin, and they're made by the genes that cause tuberous sclerosis. And I've already said in my earlier talk that tuberous sclerosis and LAM are associated. They cause the same abnormalities. So if you have LAM, this tuberin and harmatin complex doesn't switch off the mTOR pathway. It's on all the time. So the cells grow, and they can adapt to adverse surroundings and survive in places that they really shouldn't. And that's really what causes LAM. We've known for some time that the mTOR pathway is active in LAM. This is a slide from our lab, but actually it was shown by other people before this. But this is a LAM nodule looked at under the microscope. This brown staining here highlights the LAM cells, this brown staining at the bottom is an antibody that targets a protein that's activated downstream of mTOR. And so this brown staining here tells you that the mTOR pathway is switched on in the LAM tissue. Actually, in the normal lung around these little alveoli, it's not really. So we know that mTOR is on in LAM, and we know that this is the cause of the abnormal cell growth that the disease does. Where we all got a really lucky break was that there was an existing drug, rapamycin, that we know switches off the mTOR pathway. mTOR actually stands for mechanistic target of rapamycin. It's a bit of a giveaway, isn't it? The rapamycin might work. This was discovered by Vera Krimskaya 16 years ago now. And she also postulated that rapamycin might be a helpful treatment for LAM. And this little graph here just shows LAM cells growing and then increasing amounts of rapamycin. These little bars go down, so they suppress the growth of these LAM cells. So this is a potential treatment for diseases where mTOR is dysregulated, including LAM. So how might that work in LAM? Well, you've got to sort of know how sort of LAM causes disease a little bit. So as I've said, LAM occurs when you have loss of these proteins that are made by the TSC1 or TSC2 genes, the tubulin and hamartin, genes that switch off mTOR. Now, to do this, you need a mutation in the 2 copies of the genes. Every cell's got 2 copies of genes for each protein that it makes. And so to get mutations in the same gene twice in the same cell is quite unusual, and that's really why LAM is rare. So you need these 2 mutations. If you have tuberous sclerosis, you've been born with one, and that's why LAM's common in TS. So what happens is you have these mutations, mTOR is activated, and this allows these precursors to the LAM cells to grow and proliferate in places that they shouldn't. They then get access to the blood vessels and the lymphatic vessels, and they spread around in those, and they spread around the body, and they tend to build up in the lungs and the lymphatics and also kidney tissue, which they probably do by chemical signals that the lungs produce that sort of target these LAM cells to the lung tissue. When they get to the lung, they're allowed to grow where they shouldn't, and this causes lung destruction and the lung cysts that we saw earlier. Rapamycin potentially works in a few of these places. It suppresses the activation of mTOR, stops the cells growing. It reduces the chances of them getting into the circulation and spreading around the body. And when they are in the lungs, it probably reduces their growth and has other metabolic effects that our lab and other people are currently targeting. So rapamycin probably works in LAM in lots of different important places along the disease pathway. So it's a usefully tailored drug. Now, there were a few trials of rapamycin done early in angiomyolipoma in different aspects of tuberous sclerosis. But the real pivotal trial that was of most importance to women with LAM was this study that was run out of Cincinnati, funded by the LAM Foundation, in which they randomized 90 women with LAM to either take rapamycin for a year or an identical matched placebo, and they looked at their lung function. And this is the sort of main study results, really. This is lung function. This is FEV1. So this is FEV1's a measure of airflow. The lower your FEV1, the more advanced your LAM is in general terms. And we know that women with LAM lose lung function, lose FEV1 at a certain rate every year that's faster than women without LAM. So the white bars are the placebo group. So over a year, women with LAM on the placebo lost FEV1 about 140 milliliters a year. So they'd recruited people with active disease. Not everybody does this. And also the maximum breath intake, the vital capacity, also fell by a similar amount. The people who took rapamycin, their FEV1 didn't change at all. In fact, it's a tiny bit higher. Their vital capacity was also a tiny bit higher. And so going from no treatment for this disease to being able to block the reduction in lung function was a huge thing. And the study was performed by Frank McCormack. This is Frank in Nottingham. You can tell it's Nottingham by the fact it's raining. And there is Robin Hood as well. This is the long-suffering Holly, Frank's wife. But Frank coordinated several centres across the USA, across Japan, in Canada, to find 90 women with LAM to run this trial. And it was a real landmark in rare disease research, this particular study. The other thing that we learned from the MILES trial, as it was called, was that you need to take rapamycin long term. So these are the results that's shown in a slightly different way. So this is FEV1 in the patients that were treated, so fairly steady for the year. This is the placebo group. FEV1 creeps down over the year. And then at this point, 12 months, they didn't know whether it was going to work or not. They stopped the drug. Actually, unfortunately, both groups then continued to lose FEV1 as they would have done before if they were not on treatment. So what this means is that you need to take rapamycin long-term for its effect. It doesn't kill the LAM cells, it doesn't cure the disease, but it holds it steady while you're taking the drug. So it's a lifelong treatment. So the next point to say is that not everybody needs rapamycin. So this type of graph is called a spaghetti plot for obvious reasons. Each one of these lines is the lung function of a woman with LAM. So each one of these is an FEV1. And the thing that you take home is that it's really, really variable. There are people at all levels of severity, and there are different rates of progression. If I just highlight 3 people here, the person in the blue, so anything over about 80 for FEV1 is a normal value. So the person in the blue's FEV1's gone up and down a little bit over time, but the measurement's noisy. Never creeps into the my lung function's impaired regime, and this is actually 10 years of observation. So this person doesn't really have much in the way of symptoms at all, doesn't have progressive disease, and would not really benefit from rapamycin. The person in the green is, I suppose, oh yeah, sorry. This one. It was bound to happen so there'll be more fun like that later, I'm sure. So, so this person has a sort of moderate rate of progression, and then the person in the other colour at the bottom here, which I'm not going to chance it now, you can see they start at a much lower baseline and progress much more rapidly. And so the orange and red person would clearly benefit from rapamycin, whereas the person in the blue wouldn't. And you can usually tell when you see people if it's clear. So the CT scanner lady here, highlighted in blue, not many cysts, doesn't really progress, has had LAM for a reasonably long time, no changes. Whereas the person, the people with progressive disease, I don't know if you can see from where you're sitting, but there are many, many more cysts here and less lung tissue, and it's fairly obvious that this woman will need to be treated with rapamycin. So we think about the lung disease mostly. What about the other manifestations of LAM? Well, half of women have these angiomyolipomas, these benign kidney tumours. And about 20% of women will have build-up of chylous fluid either around the lungs, as in this case, this is the chylous fluid here, or in the abdomen, as in this scan. Rapamycin also is useful for treatment of these complications. The same molecular abnormality in the LAM cells exists in the angiomyolipoma tissue, and in the cells that are gumming up the lymphatics and causing these pleural effusions. The group at the National Institutes of Health in the US reported a nice case series quite a long time ago now about women with chylous complications who were treated with mTOR inhibitors, rapamycin in this case. So these are 2 examples. This is a CT scan of someone with chylous collections. The dark areas of the lungs, the chylous effusions are quite big and they're squashing the lung tissue. And this is a patient with a lymphatic growth in the abdomen. And you can see this great big thing here on the CT scan. That's probably about that big in this woman's abdomen. And both of these complications were really pretty much untreatable before we had rapamycin. And these are the after pictures. It's sort of almost like they made these up. I mean, the chyles completely vanished from this CT scan. This is the same person at the same level about a year later. And perhaps more remarkably, this big mass here has completely gone. And so what's happened here is the rapamycin has rearranged the lymphatic channels to allow the drainage to be more normal. Now, because you need to remodel your lymphatics, the full effect of rapamycin for the chylous complications, it takes really up to a year And we often see people with these chylous effusions, we treat them with rapamycin, and before rapamycin, this is a terrible problem. They needed the fluid drained off very often. It was actually a really difficult clinical problem. And people often get a bit impatient, but usually we can get rid of these problems. But it often takes a few months to make an impact on that. But it's really transformed the treatment. Angiomyolipoma works. You can treat angiomyolipoma. I'm showing this study, I fairly fondly remember it. Nowadays, we have some research nurses from the City Hospital now. They would be horrified by the research team that did this study, which was 2 people, and Tattersfield and myself. No research nurses, no trial coordinator, just the 2 of us. Anyway, but it was a long time ago now. And it was one of the very early studies of rapamycin. I think we started about 2005 or something. And this is an MRI scan, actually, of an angiomyolipoma in a woman with LAM at baseline, and this little line marks out the tumour. Then we treated her with rapamycin, and after 2 months, you can see that the lines got smaller and the tumour had shrunk. And in fact, it was a small study, I think about 16 people, and this graph shows the change in size of all the angiomyolipomas we treated, and you can see they all got smaller with the drug, which was a huge result at the time. And this was sustained for about 2 years. At the same time as this, there was a similar study being performed in Cincinnati, which showed exactly the same results. So rapamycin works for the lungs, for the kidneys, and also for the chylous complications. One of the questions that you get to, you see clinical trial data, and in a clinical trial, perhaps not in our one, but usually everything's very closely monitored. All of the patients are very carefully chosen to exactly fit the criteria, and you often see good results in clinical trials, and then when you start to treat wider numbers of patients, perhaps the response isn't quite so good because the patient isn't quite so suitable. So what happens in real life? This graph is data from our centre in Nottingham, and each one of these points is not one single lung function measurement, but the rate of change of that, so how active the disease is. So the lower it is here, the more active the disease. This is before rapamycin. This is about 2 years of observation on average, and this is 2.5 years of observation after treatment of rapamycin, so this is change in lung function. So you can see everybody that we treated, that we had enough data on to put on this graph, their change in lung function improved. There were similar results from other centres. This is a longer-term study out of China, again looking at changes over 2.5+ years. And they've represented their results slightly differently, but each one of these lines is a patient. Rapamycin was started here. So you can see most of them are going down here, and then they tend to level out, or some of them increase a little bit, then level out after that. So we think rapamycin is effective for the wider groups of patients. There are also improvements in quality of life. Of course, so that's all good. But what about the side effects? People are often, we spend quite a lot of time talking about this in outpatients. And the bottom line is most people who we treat with rapamycin will have side effects. So what we did, we looked at the common side effects of rapamycin. And as some of you will be able to say, the common side effects, mouth ulcers or aphthous ulcers, it's caused here, nausea, acne, changes in menstrual cycle, edema or ankle swelling, and diarrhea. Now, I'm not going to do the colour thing here, okay, so you're going to have to sort that out for yourself. But what you can see are, we looked at the levels of side effects after several months of treatment. And you can see after the first month, when we re-evaluate everybody when they've been on the drug for a month, over half of patients have mouth ulcers. About a third of them have diarrhea. And about a quarter of them have at least some degree of nausea. The good news is, as time goes by, these side effects drop rapidly. And this final point here, this is about 2.5 years out. Most of these side effects are quite low level and just sort of occasional mouth ulcers. The acne and diarrhea sometimes persist. And I'm sure if we have the patient discussion afterwards, people might mention that they still have side effects, although perhaps they're not as frequent or as bad at the start. We're quite interested, obviously, in minimizing these side effects. And we looked in this study at whether these were related to the amount of drug you were receiving. And so people metabolize rapamycin differently. So we don't really look at the drug that goes in. We look at the drug level in the bloodstream to look at this. And what we've done is measured the rapamycin levels in people's blood after a month of treatment. So if the rapamycin level's less than 3 picograms per milliliter, then about sort of 40% of them will get mouth ulcers, but other side effects are pretty much unseen. If people are on higher doses here, then they're more likely to get nausea, they're more likely to get diarrhea. So the side effects seem dose-related. And if we look at this over a year, we see there are more side effects because it's cumulative over a year, but we see a similar pattern with the lower doses, which we're currently using now, associated with fewer side effects. And if you look at this statistically, the number of major side effects from this group are related to the serum level of the drug in your bloodstream. The other things we subject people to are blood tests, and really this is to monitor the things that rapamycin does internally. And people need to have blood monitoring when they're on the drug. And what the common things we see, we measure loads of stuff, hemoglobin, liver, kidney function. Most of that's all fine, actually. The main thing that we see is an increase in cholesterol levels. Average cholesterol in the UK is about 5 or something. And this is women with LAM before and after treatment, and it usually goes up by about half a unit. It's not really related to the level of the drug in your bloodstream. The other thing that we see is that one of the things that rapamycin does, it affects the filtering mechanism in the kidney to some degree, so the kidneys lose a little bit more protein when you're on rapamycin treatment. And again, this is treatment with rapamycin, looking at urinary protein levels. These error bars mean that it's quite a variable measurement between patients. So there's a slight increase, but for most people it's not a problem, and it tends to sort of right itself eventually. Again, the change is not really correlated with the serum level particularly. So there are side effects, they're common, they tend to reduce over time. They don't tend to be too severe. Not many patients have stopped rapamycin due to side effects. In fact, no one stopped due to the standard side effects at all. And the blood monitoring has usually been reassuring. And these data go for an average of nearly 3 years, with some people having been on the drug for significantly longer. Another thing that we can reassure people over is the risk of infections. So rapamycin's original use was to suppress the immune system when you'd had organ transplantation. So most of the experience was in people who'd had kidney transplants, and most of the side effect data came from that group. Now, those people also are on lots of other drugs to suppress the immune system, so the data was not very straightforward. If we look at people who only receive rapamycin, no other immune suppressive treatments, just for LAM, we see that there's not much of a change in infections either. This was a really helpful study, I think, done by Sohail El-Chamali from Harvard. So what they did was they took all the people in all the trials of LAM and placebos, because they have their infections monitored quite carefully. They've had 93 patients in clinical trials, and they looked at the number of infections a year they got, and it was about 0.7. So there's about a 3/4 chance that you get an infection once a year. If you look at people treated with either rapamycin or everolimus for LAM, and there were nearly 300 people of those in clinical trials, and you look at the number of infections, it's actually, if anything, a tiny bit lower, not a significant number. But what this does show is that rapamycin does not predispose you to infections. You can still get infections when you're on rapamycin, but it doesn't really increase the numbers of them, and I find this quite reassuring for people. I'm going to talk a little bit now about the response to rapamycin and what people can expect. And I've shown you that everybody's lung function that we have data on seems to improve. What I'm going to say now is that the response is really quite variable. So this plot here is change in FEV1. So if you're getting your FEV1 loss is turning into a positive, it's this side. So if you're on this side, the further you are, the better you're doing on rapamycin. This is lung function not changing at all, and this going out this way is lung function still falling on rapamycin at this sort of level. So you can see there's actually quite a big range. And all of these people are doing a bit better now than they were, but some of them are still losing lung function at a significant rate. So we were really interested in what were the factors associated with a good response to rapamycin. We want everybody to do well. Can we target those patients? What can we do? So we looked at lots of different data from all of the patients that we treated. And what we did was we divided the response to rapamycin up into groups of 4, or quartiles. So we took the quarter of patients that did the best, and we compared them with a quarter of patients that had the smallest response to rapamycin. And so what we saw here, in terms of who did better, who did worse, actually the people who did better had the faster rates of lung function loss before treatment than the patients who didn't do quite so well. And these figures, they're slightly complicated, but the people who did best tended to have the more active disease when we offered them treatment. But they had slightly better lung function at the start. And the other thing is they'd had LAM for an average of about 6 years, whereas this group had had LAM for nearly twice as long. So if there's a sort of take-home message from this, I think, it's that you probably want to offer treatment perhaps a little earlier than we had been offering treatment before, I would say. What's also important is that the difference in the level of rapamycin in the bloodstream is not significant between these two groups. So what this also means, we don't need to use big doses of rapamycin to get the benefit so we can minimize the side effects. We perhaps just need to target people a little bit earlier. We also looked at changes in disease, and actually people with the lymphatic type of disease tended to do a bit better as well. So what does all this mean for you if you're thinking, should I take rapamycin or another mTOR inhibitor? Well, the things are, this is pretty obvious, isn't it, really? Treatment, is it likely to help? So it's not going to help if your disease is stable. If you've got lung function decline, it's likely to help. If you've got difficult chylus problems, it's certainly likely to be helpful. Or if you've got complicated renal tumours that we can't fix by physical means, by the standard treatments, then perhaps rapamycin would be helpful. I haven't had time to talk about this morning, but there are other benefits for patients with tuberous sclerosis-related LAM. The same molecular change in tuberous sclerosis causes the brain tumours, causes the skin disease, causes the epilepsy, and all of those things probably improve on rapamycin. So if you have tuberous sclerosis, it's, and there are lots of reasons why you might want to take an mTOR inhibitor. There's data from Cincinnati suggesting that the patients with higher VEGF-D levels do a bit better on rapamycin, and that certainly was the case when we looked at that too. And the hint from our data is perhaps we should be treating people a little bit earlier before they lose lung function, perhaps before the disease gets less responsive. Of course, you have to understand the risks and the side effects long-term. It's a long-term treatment, and I think the maximum duration we've had people on treatment for is probably 10 or 12 years. So we don't know the full long-term side effects. And of course, you need someone to sort of look after. You need someone to prescribe the drug, and you need someone to monitor it and tell you all the do's and don'ts. And Sharon, our nurse specialist, who a lot of you may know, spends a lot of time talking to people about side effects, about drugs they can't take with rapamycin, making sure they get their monitoring done, and that sort of thing. And that needs to be done carefully so people don't come unstuck with the drug. And just say that mTOR inhibitors, rapamycin, everolimus, reduce decline in lung function in LAM. They improve Kyler's complications, they reduce angiomyolipoma size, and they have lots of benefits in tuberous sclerosis. Treatment's a lifelong thing at the moment. So once it's not the sort of thing, oh, we'll just try this out. Usually when people go on it, they're on it for good. Side effects are very common and reduce over time. We haven't seen too many adverse effects. Infections don't seem to be too much of a problem, but we really don't know much about what's going to happen in 10, 15, 20 years' time. So there's still some note of caution there. The other, rapamycin isn't the only thing you can do for your LAM. I had some other slides which I'm not going to show you, but don't forget to do all the other things. And when people come to Nottingham, so we often give them rapamycin, and they usually come to, I'm sure as they're driving over there, oh, I'm going to go over there, he's going to nag us again about keeping active and losing weight and, using our other meds. And all of these things are important. And if you make small improvements in as much as you can, they call it marginal gains in cycling, then the overall effect is actually quite big, even though the small changes that you make may not seem important. So yeah, you need to optimize all of your treatment and your lifestyle to do this. I really wanted to do sort of two things. I wanted to sort of say thank you to everyone who's consented to allow their data to be monitored so we can do these types of analysis. So our research volunteers for LAM Action to funding the lab a lot, the people at the LAM Centre for collecting the data. Jan spent a lot of time analysing lung function data, and I was going to show some of her data, but we haven't quite got time today, so sorry. I'll probably be in trouble for that on the way home. But she's worked very hard to get data on bronchodilators. I guess that's going to be for next year now. Actually, it was three things I wanted to do. Rapamycin is a tablet. And at the moment, when you take the tablet, it's systemic, and some of the side effects that you get are because rapamycin hits every organ in the body. LAM, although is systemic disease, most of the features are in the lungs. And one of the new things that people are trying now is an inhaled version of rapamycin. And in Nottingham, there's a clinical trial of a new inhaled version of rapamycin for LAM. And we're looking for patients to recruit to try that out. And two of our research team from Nottingham are here today. Do you want to stand up, guys? So they've got to stand outside. They'll be here over lunch. Charlotte and Nico will be very pleased to talk to people about the study. We're looking for people who aren't on rapamycin, clearly. So we can look at this. So it'd be really great if anybody's interested, talk to the guys. And even if you're not eligible, they'd be very happy to talk to you about clinical trials and things generally. How long have we got there? And I had hoped to have a little bit of a chat about what people's, So we've got 5 minutes. So if we could perhaps just talk a little bit about people's experience of rapamycin. The things I've observed, people are often concerned about side effects, so it would be sort of helpful to talk about that. Sometimes when you tell people that you think it's time for them to start rapamycin, they sort of think, oh, really? I thought I was doing okay, and that probably means I'm not. And sometimes it takes a little bit of time for people to come round. It's not necessarily a bad thing to start on rapamycin to prevent loss of lung function. It doesn't necessarily mean you're not doing that well, especially as we're now using it easily. And really, anything particularly good, bad about rapamycin, I'd be really interested in hearing people's views. Anybody like? Yes, Kelly.
I think a lot of us would say that we think we've had a lowered immune system reaction to the drug. Okay. So if that's not the case, according to your statistics, what might be the cause of that?
Okay, so I suppose, the data I showed says the number of infections doesn't change. it doesn't say, maybe if I get an infection, I feel a bit worse with it, or it's a bit harder to fight off. So those things are possible. So that would, that might say, well, I don't feel my immune system so good. So you don't get more infections, but maybe it's harder to fight the drug off. And how many people stop their rapamycin if they take antibiotics for an infection? Yeah, so a few people do that to sort of give their immune system a better chance to fight infections. I mean, is it people's perception that they get more infections on rapamycin? Okay. It's always tricky, isn't it? So the data, so 300 women with LAM and on rapamycin against 90-something in the placebo group. Do you think it's more, or do you think it's do you think they last longer, or they just feel a bit worse? Or okay. So I mean, the important thing is that you take when you have LAM, and particularly when you're on rapamycin, you take infection seriously. And it's very often so some women with LAM are quite prone to getting infections, and some not so much. And I think if you are one of the people that's prone to infections, it's sensible to have your GP on board, to have some antibiotics at home. So if you get an infection on a sort of Friday evening and you ring the GP, oh yes, we can see you on Thursday. You can start the antibiotics, still go and see the GP, but actually the whole thing hasn't got a hold. So you can take some sort of active effects. Obviously, it's important to get vaccinated against infections. Any other points about side effects? Were they as bad as people thought? Hi.
In the first couple months, or 3 to 6 months, the mouth sores and the nausea were severe, and then it kind of went down. So over time, I haven't found any major problems. I haven't had any major infections, and acne is still, a really irritating issue. But other than that, it's been wonderful in my experience.
Yeah, I mean, as you say, the mouth ulcers seem to reduce. The acne is one of the things that hangs around. It's slightly, yeah. There are some topical treatments that some people find effective. Have you tried those? And,
yeah.
Yeah.
I'll take it.
Okay.
I resisted going on rapamycin for far too long. I know we should have started it 2 years previous. As you know, I'm normally quite well and fit, touch wood. But I didn't take it because of I was worried about the side effects, and I think I built that up too much. And we should have just started it sooner.
Well, I mean, maybe your doctor should have talked you into it more. Oh, that was me, wasn't it? Yeah. I think at that time we were using rapamycin in people with perhaps slightly more advanced disease, and so people who are sort of doing pretty okay without it, we tended to sort of not push treatment quite so hard. Now we're learning a bit more about it. We're sort of realizing actually we probably should be starting a bit earlier for some people. I think if had you been diagnosed today, we probably would have been pushed you on it a bit longer. And I think, a lot is made of the side effects, and everybody gets them, and it's a lifelong treatment, and you can see why people step back from it. But I think
that's the point I'm sort of trying to make. Don't be frightened of going on it. It's not such the big deal. It's sort of made out to be. Really.
Do other people sort of have had similar experiences? Or?
Absolutely. Initially I had a few side effects, and it wasn't very pleasant. But it does all settle down, and it's fine. And I was on a double dose of what I used to be on, and you've recently lowered me, and it's all been good. And
that's the other thing that's changed since you've been on treatment is that the Miles trial used doses of 5 to 15 picograms per mil in the blood, and now we're using less than 5. Sort of 2 to 5 routinely. So we've cut lots of people's dose down, and I think Frank does the same thing, Sue, doesn't he? He's using lower doses, which is good for long-term side effects and things. Sorry, yeah.
Just one last one. You used to talk about the side effect of a very serious form of pneumonia called
Rapamycin pneumonitis, yeah.
Yes, but that's not mentioned anymore.
So rapamycin pneumonitis is a lung inflammation that it has been reported with rapamycin, mostly in cancer trials where people have slightly higher doses. In LAM, it's been mostly reported in a Japanese population, and people on Japanese background tend to be more prone to drug side effects generally. It's a genetic predisposition. And so rarely in some women with LAM, and I haven't really seen it in the UK as far as we know, tend to get lung inflammation. But so yes, it was certainly a concern at the beginning. I'm not sure I've seen a case in the 70-something people we've treated with rapamycin now. So it's something we do warn people about it when they start on the drug, and we do look out for it. But
Still do that.
yeah, but we haven't really seen a lot of it. So yeah.